closely at about 11 o'clock, and you can see it's a white subretinal lesion which is smooth, and there appears to be some hyperpigmentation of the retinal pigment epithelium just overlying the lesion. Moving to light microscopy, I'd like you first to look at this image here. This is a picture of a normal human cornea, and you can see that this is corneal epithelium, Bowman's layer, the corneal stroma, Descemet's membrane, and the endothelium. Now, this is a similar section from our patient, specifically this pupil optic nerve or PO section, and you can appreciate that comparing the epithelium has been lost over here, and additionally you can see that this patch over here, there's increased staining suggesting a corneal scar, and the corneal scar appears to have replaced Bowman's layer. At high magnification, you can see this. This is a pannus which is growing across over the limbus, and furthermore you can see these little black dots here are actually inflammatory cells which on further immunohistochemical staining was found to be CD68 positive, and therefore we think they're most likely macrophages. The left eye showed similar sun-induced damage. What happens is that this is the conjunctiva, and you can see here that it's thickened, and the substantia propria appears to be completely replaced with this dense collagen fibers, suggesting that this is a conjunctival scar. The left cornea is similar to the right cornea. What you can see here is this, the corneal epithelium has been completely lost over here, and once again, you can see this area of increased staining suggests a corneal scar. So both corneas are scarred. At high magnification, this is what we saw. Similar to the other eye, you can see that the corneal epithelium has been lost. Bowman's layer has also been lost over here. And once again, these little black dots over here are inflammatory cells. Moving posteriorly, we found the beginnings of a cataract. So this is anterior and this is posterior, and this is the lens. And if you look here in this blue circle, you can see this fragmentation of the cataract's lens fibers, where the lens fibers appear to be retracting from one another. Furthermore, on this side over here, what's happening is you're developing liquefaction of these peripheral lens fibers, and they're forming Morgagnian globules, which are these little circles over here, suggesting that this is the beginnings of a posterior subcapsular cataract. The left eye is similar. This is a light microscopic photograph of the left lens. This is anterior and this is posterior. Now, normally your lens fiber cells shouldn't actually go past your equator, and your equator's here. And if you look here, down here posteriorly by the posterior capsule, these little two dots here are lens fiber cells that have migrated posteriorly, suggesting the left eye has also got what appears to be the beginnings of a posterior subcapsular cataract. An incidental finding we happened to notice was a retinal tuft. A cystic retinal tuft is a congenital abnormality that's composed primarily of glial tissue. The main clinical finding of something like this is that classically you're supposed to get strong vitreoretinal adhesion from lesions such as this, and you can sometimes get small round holes or horseshoe tears around here. Retinal tufts are present up to 5% of the population, but it is thought the actual risk from retinal detachment is low, and is thought to be probably well below 1% for actually any particular retinal tuft. Regarding the optic nerve, this is what we found. This is the posterior optic nerve. This is anterior and this is posterior. And what you can see here is that this is this increased septi in the optic nerve, which is a sign of optic atrophy. The left eye is similar. The left eye once again shows this increased septi, suggesting bilateral optic atrophy. Moving on to our lesion itself, this is what we found. The lesion was found to be composed of these tightly packed basophilic cells, and they appear to be arranged in whorls over here and also in nests over here. The lesion was vascular. There were a few blood vessels over here, here, and here, and we actually found it to be composed of spindle cells, which I'll speak more about on the next slide. This is, if you look on the left, is a traditional spindle. A spindle is a tool traditionally made from wood, which is used to spin wool or cotton into yarn. And with the eye of faith, if you look here in this patch over here, you can see that these cells appear to mirror the spindle, and they appear to be long, slender, and spindle-shaped. But the important thing is that we can't only find any obvious dark stripes of a spindle A morphology or the prominent nucleoli of a spindle B morphology. Now, the clinical significance of the cell type is that if you have a choroidal melanoma with epithelioid cells, those tumors tend to be more aggressive than those made of a spindle or mixed cell morphology. Other things we found at high magnification, we found some melanosomes over here, and there are also some vacuoles above. And this is just another diagram photograph showing the vacuoles over here. Lastly, unlike microscopy, here are the vessels I mentioned earlier, showing that our tumor is fairly vascular. So, onto the immunohistochemistry. Historically, S100 was one of the first immunohistochemical markers for the diagnosis of choroidal melanomas. And the reason why it was the gold standard was because it was very sensitive. So anywhere between 96, it could pick up anywhere between 96 and to 100% of malignant melanomas. However, the main problem with S100 was a lack of specificity. Sometimes it would pick up dendritic cells, and therefore that would lead to false positives. Now, looking at our lesion here, this is the S100 immunohistochemical staining of our tumor, and you can see it does stain with S100. It seems to be fairly black colored. However, the next stain we tried was human melanoma black 45, or HMB45. This was historically the next immunohistochemical marker to be used for melanomas, and it was discovered by Drs. Gowan and Vogel in 1986, and it's a mouse monoclonal antibody that's been raised against GP100, which is a melanoma-specific marker on pre-melanosomes, and its sensitivity is high, anywhere between 50 to 100%. Now here, when we apply HMB45 to our tumor, you can see that the lesion is much more convincingly stained and much darker than S100, suggesting that our lesion is definitely a malignant melanoma. We tried other things. We tried NSE, or neuron-specific enolase. This is a marker that looks at neuronal and neuroendocrine tissue, and interestingly, if you do aqueous taps on patients with malignant melanomas or retinoblastoma, you can find NSE in these patients. And you can see that our lesion also stains convincingly for neuron-specific enolase, demonstrating possibly a neural component. We tried other neural markers. Another one we tried was CD56. It's also known as neural cell adhesion molecule, and this picks up tumors of the nervous system. However, as you can see, that when we applied CD56 to our lesion, it doesn't really stain as positive as the previous two images. The last immunohistochemical marker we tried was GFAP, or glial fibrillary acidic protein, which picks up glial tissue. But as you can see, is that when we applied it to our tumor, it doesn't stain as positive as the previous images. Lastly, we had some colleagues downstairs in pathology who were kind enough to do fluorescence in situ hybridization of FISH on our lesion. The reason why we did this was because the modern management of choroidal melanomas, the best practice is to do chromosomic analysis because it has a direct link with prognosis. So, for example, if you have complete or loss of chromosome 3, your 5-year survivability from choroidal melanoma was reduced from 100% down to 50%, and other chromosomal abnormalities that are linked with a poor prognosis include loss of 1p, monosomy 3, loss of 6q, or gain of chromosome 8. The non-monosomy 3 is the most important. So what we did here is that this is just a picture of 2 chromosome 3s, and our colleagues downstairs used a red probe looking at the centromere in for chromosome 3. And with the eye of faith, if you look sort of over here, you can see there's one red dot and there's another red dot over here, suggesting that these 2 cells here have got 1 chromosome 3 each. If you ignore this bit over here, but if you look at this cell over here, with the eye of faith, you can see possibly about 3 red dots over there, suggesting that this cell over here has got 3 copies of chromosome 3, whilst if you look over here down by this green cell, this has got 2 red dots, suggesting 2 copies. So what we have here is that on this FISH image of our melanoma, you have a heterogeneous cell population, and computerized image analysis suggests that roughly 50% of our tumor was composed of cells comprised with monosomy 3. So, to summarize, this is a summary of the findings that we found at autopsy. As mentioned by Drs. Kramer and Brooks earlier, we found a lot of anterior segment signs. So both eyes had conjunctival scars, both eyes had corneal panuses or pani, and both eyes had corneal scars. We also happen to notice a cataract. So that's the pannus and that's the conjunctival scar. Moving posteriorly, we happen to notice a little bit of cystoid retinal degeneration. We noticed a retinal tuft, some drusen, but the main ophthalmic finding was this amelanotic choroidal melanoma. We noticed they had a spindle cell morphology, and also we noticed that because it stained intensely for neuron-specific enolase, we decided it had a neurotrophic component. Lastly, as mentioned earlier, the patient had bilateral optic atrophy, and we think that this most likely was due to the fetal alcohol syndrome, because Stromland in 1982 described a cohort of children who had fetal alcohol syndrome, and he found that about 13% of patients with fetal alcohol syndrome can have bilateral optic atrophy. So that's what we're thinking there. To summarize, we describe a 20-year-old young man with xeroderma pigmentosum, a combination group type C. The main ophthalmic finding was a supranasal choroidal melanoma, and which had spindle cell morphology and was positive for the melanoma markers of S100 and human melanoma black 45. It was also positive for the neural marker of neuron-specific enolase, and on FISH imaging, roughly about half the cells had monosomy 3. I'd like to thank other colleagues in my lab for their help in preparation of this talk, namely Drs. Chan, Guedes, Abu Assad, and Messrs. Pop and Odeljan. And also I'd like to thank our colleagues from pathology, Drs. Pak and Abdullayev, for the help in the Fluorescence Institute hybridization. Now I'd like to move on to Dr. Abu Assad, who will present the electron microscopic findings.
Thank you, Ian.
So there was concern about the FISH studies because this fellow had chromosome abnormalities in his bone marrow. And we wonder if any normal tissue was not melanoma tissue was tested or ought to be tested the same way. So make sure he didn't have widespread chromosome.
At the time, we only tested the tumor tissue, but we have spoken about this recently. We only tested the tumor tissue.
Dr. Kramer, usually this is findings inside the tumor and